I'm very happy, first of all, to present to you our new logo. We just was nominated to be a WHO Collaborative Center on HIV and Viral Hepatitis, and we'll be working with the European WHO office to work to improve the situation across the continent. We are very late in the day, so I'll jump over some of the slides because many of those points you have heard now several times, so there's no need for me to repeat them. But I have to show this slide. I mean, I just have to show this slide because it gives the impression that we are in a crisis situation. We had a stable epidemic, more or less, until 1996. At which point the epidemic in Eastern Europe completely took off and is just increasing every year at a rate of around 100,000 to 150,000 new infections. On the other hand, in Western Europe, there's a fairly stable, although slightly increasing number of people with HIV. This slide is from Russia. It gives you the number of new infections per year, and it shows you the tremendous ability of having HIV spread in a community of people that is sharing unclean needles. Over a few years, you can see a tremendous boost. And of course, as you would expect in any outbreak, if that's not contained, if not handled appropriately by public health authorities, and therefore the reservoir for continued transmission persists unaddressed, you will expect to see a second wave of more mixed pattern, much more heterosexual transmissions. And that's how any outbreak will behave, not only HIV, it's for anything we know of that is contagious. And again, the numbers continues to increase, reflecting a absolutely inadequate public health response to this situation. I've shown this slide earlier today. I think it's still important to remind ourselves that the number of infections, and those are the diagnosed infections, are outcompeting the number of people that we put on treatment. So there's an absolutely problem in terms of how the infrastructure in the health systems actually behave in response to that. Not only in terms of diagnosis, we'll come back and discuss that, but also in people who is well aware of the situation. We are not putting them on treatment at a sufficiently quick rate. And that is, and I'm afraid to say, in Eastern Europe, is not an issue about finances primarily. It's an issue about political will to actually do this, which makes this disease not only a medical and financial issue, but now this is a major public health and policy issue as well that we need to tackle. I've shown this slide as well. It's just have to dwell on the fact that we have 45 to 50% of people in Western Europe who is well suppressed, whereas less than 10% are on treatment in Eastern Europe. This is it's a slide that I like to present to people to remind them that in the best of clinics, we can maintain suppression over extended periods of time in most patients. You can express this with the proportion of follow-up on ART, where at least 90% of the follow-up time is spent, while the viral load is less than 500 copies. That's an operational way to look at this. And you can see that this is possible and has been possible for quite a number of years. It has increased slightly over the last decade across the continent. But it's equally clear that there's a tremendous variety in the ability to do that depending on which region you're living in across Europe. There's a difference around 35 to 40% in 2001, and this difference remains in 2011. So we're not even able to really, across the continent, even for people that is put on treatment, to actually maintain durable suppression. In Eastern Europe, the biggest problem that I can see that is preventing a better care standard is not only accessing antiviral treatment, but is also accessing opioid substitution therapy. There's a large number of drug users living in that region, and you can see around 1%. And in some countries, the biggest one, Russia, 0% on opioid substitution therapy. And as a consequence, very few of the drug users actually get on treatment, because you can't maintain a drug user on antiviral treatment if you don't have an appropriate care for the addiction that this patient is suffering from as well. Of course, the coverage rate, for those who may not be aware of this, the OST coverage rate in Western Europe is around 40 to 50 to 60% of the number of people who is drug users. The issue with late presentation has been discussed. We have said that it is slightly improving. Indeed, our report that we published a couple of weeks ago in PLOS Medicine was suggesting that it is slightly improving. We've just seen the update from 2011-2012. That improvement has not been sustained. So there's absolutely nothing to celebrate about that we have seen a slight reduction in late presentation. We are still at around 50%, and we have heard, depending on which country we are in, that this percentage is actually higher. This is absolutely not good enough, and we need to work on that in the future. The testing strategies we have been discussing today, they're very clear, and as I made also the point earlier today, whatever we have done since testing became available in 1985 has not been working well enough. So to just continue what we have been doing so far is just not helpful. We need to think about new ways of doing this, and we need to empower the health system. We need to empower community testing facilities so they can get more people tested in the key affected populations. One of the most exciting areas of this work that I have been involved with is indicator condition guidance testing. We put out a report earlier this year showing, just for the record, that these diseases that you can see here, if you get people tested for HIV, if they present with each one of those conditions, the HIV prevalence, you can see, ranges from 0.4% to up to 4% of people that was tested were actually HIV positive. So this works. This is cost effective. This makes sense. But I think what is most exciting in this list is ongoing mononucleose-like illness, 3.8%. So what is this? Well, what is this? Well, it's obviously not mononucleosis. It's not EBV infection. It is probably acute HIV disease. So if we can have an indicator and we can get the general practitioners to start screening people with mononucleose-like illness, we may be able to capture people as they were just infected. If I can find an indicator that is the most optimal, that's an indicator of acute HIV disease. If this is true, and we're working very hard at the moment to substantiate that finding, this will, in my opinion, create a paradigm shift in how we focus on testing for HIV, because then it becomes absolutely critical that general practitioners, if people are coming to them in mononucleose-like illness, that they not only screen for mononucleosis, but also for HIV. It will make sense. It's evidence-based. It has to be that way. The issue around testing for conditions is something we have been spending a lot of time on, and we will have to continue to do that. It's a major challenge to get our colleagues in other specialties to do this. We did an audit of very established indicator conditions. We're talking TB, non-Hodgkin lymphoma, anal cancers, cervical cancer, hepatitis, and esophageal candidiasis across Europe. Many different clinics were audited to see were they actually offering an HIV test to the patients that present with each one of those conditions. And no, they were not. Actually, the region that performed best was the eastern region, and for good reason, because essentially they don't treat their patients, so as they get into the hospital system, that's where they get their HIV diagnosis. But it's just not good enough. In Northern Europe, in the region of Europe where I come from, only 1/3 of the audits were actually having a satisfactory offer rate. somewhat better here, but absolutely these numbers need to be more, going up to 100. And we know that we can do this. The antenatal care testing success and for all countries across Europe, the latest ECDC report from 2011 that I've seen just now is supporting the same thing, that essentially it is possible in any healthcare systems across Europe to test pretty much all pregnant women. So why is it, if we can do that, that we can't test people for something which is actually much more clear, like people who present with a potential AIDS-defining disease? The condition-guided testing guidelines that has been released, I hope will be used by many. There's a lot of other challenges in relation to testing. We need to, of course, ensure that key affected populations get better access to know their status. That's clear, that's evident, everybody agrees on that. We need to normalize testing. We need to look very carefully at the need and the extent of the need of pre-test counseling. We, of course, need to continue to respect privacy and confidentiality and human rights. That goes without saying in this room. We need to ensure linkage to care. I've just seen some reports, in particular in community-based testing facilities, where between 40 and up to 50% of people who have found positive never transitioned for that community test facility into the health system. That's absolutely not good enough. One thing is to test people, but if we don't link them into care, that's not good enough. And of course, we need to reduce stigmatization caused by policymakers. The homophobic laws that we see in many Eastern European countries are just amazing. I don't really understand what they're trying to do here. Exclusion of injection drug users from health systems is another one. Exclusion of HIV-positive immigrants from accessing healthcare and clearly criminalization of HIV, all done by policymakers, but also by society at large. We certainly should all think that HIV-positive persons deserve our empathy and compassion and not the opposite. Another area that I think is very challenging at the moment and will remain so and very controversial in the years to come is when to start antiviral treatment. Something that is so effectively working is being discussed so confusingly in the public arena and has been in the last couple of years. The confusion stems from the fact that people have very big difficulties in separating benefit to the individual versus benefit for the individual sexual partner versus societal benefit. So what do I mean by that? Guidelines at the moment are focused very much on when to initiate treatment for the benefit of the individual, and we disagree. I mean, this traffic light in terms of some guidelines are suggesting a treatment for everybody essentially, whereas others are not, is not good enough because all the guidelines are looking at essentially at the same data. So why is it that we can't agree on something as simple as when people should be started on treatment for their own benefit? It's important to make that decision, because there's a lot of people that after time of infection will actually maintain a high CD4 cell count and will maintain themselves in good health without antiviral treatment. Only after 5 years of infection, only around 50% are in need, based on this publication from a couple of years ago from the Cascade study. Of course, the other issue we have to face ourselves with is the basic medical conundrum of first do no harm, primo non nocere. So the doctor should not prescribe medications unless he or she knows that the treatment is unlikely to be harmful. And could antiviral treatment in certain situations actually cause net harm? Well, it is possible. We don't know at the moment, but it's possible. We know that there's a low risk of morbidity and mortality in early HIV infection without ART, in particular among younger people, who's obviously overrepresented among persons with early HIV. And therefore, if antiviral treatment is beneficial for organ disease and cancers and all the things we're discussing, you need to treat a lot of these people for one of them to benefit from treatment. It's not really very wise to do that. On the other hand, we know that ART causes adverse drug reactions, We know the risk is low if you're using modern drugs, so therefore you need to treat many for one to be harmed. But of course, if the numbers that will be harmed is larger than the numbers who is benefiting, then ART is of net harm. That's the problem. That's a problem if we start to use treatment in this situation. And if it is correct, then we will know that in the next 3 or 4 years, as we have a large study who is now finally enrolled, namely the START study. This will have major implications for how we deal with this whole area of using ART, not only for individual benefit, but also for prevention benefit. Of course, the societal benefit of antiviral treatment is clear. Essentially, if we tested the whole world every 6 months, so 6 billion HIV tests every 6 months, and anybody who was found positive, if we put them immediately on treatment and they accepted that, and we could maintain on full suppression, then essentially we could get rid of all transmissions globally. This paper, this seminal paper published in Lancet in 2009 from WHO, made that point based on mathematical model. The question is, however, is this a realistic scenario to think about? Well, a couple of years later came the HPGN 052 study that showed very clearly that at least for heterosexual serodiscordant couples, if you put the person, the HIV positive person on treatment, the risk of transmission to the HIV negative was much, much reduced compared to deferring antiviral treatment. But these were mostly heterosexual couples, and they reported a high frequency of condoms. So this benefit was in the context of using condoms as part of the sexual relationship. So what is unknown from this study is, will this work in IDUs? Will this work in couples who don't use condoms? Will it be effective in men who have sex with men? And what is actually the population benefit from this? Give you an example of why I'm slightly concerned about this and why this, I think, is posing a challenge to us as we move forward. The situation among MSM in the UK, there is an increasing incidence of HIV in the last 10 years, despite gradual larger HIV coverage. So essentially, despite more people on treatment, actually more HIV transmissions is observed. It shouldn't be that way. It should be the opposite way, right? More coverage, less incidence. But it's actually going in the same direction. There's also more condomless sexual behavior in the population. And I'm just explaining now the UK situation, but you will find this in many MSM communities around Europe, that we have the same trends. More people on treatment, high incidence of HIV. And Phillips published in a journal recently, based on a mathematical model, what would have happened if all condoms were dropped, essentially in the year 2000. So all, of course, the HIV incidence would have been much higher than it was actually observed. But on the other hand, had there been no change in sexual risk behavior, this number would have decreased since there was more antiviral coverage. And of course, one of the issues that we have, and where antiviral treatment is a challenge to work as a preventive tool, is that a viral load is so high in the first couple of weeks after infection, and therefore between 20 and maybe up to 50% of forward transmissions actually occur during these few weeks where the just recently infected person is most contagious. It can be estimated that the source of new infections in the UK setting, but again, similar data can be shown for other countries, that 82% of the new infections are from people who are still not diagnosed themselves. And it can be modeled that if the testing frequency is increased to 68% of all MSMs per year, so 2 in 3 of the MSM population actually get an HIV test a year, compared to approximately 1 in 4 at the moment, this will reduce the incidence of new infections by 25%. So this interplay between having more antiviral treatment, increasing incidence, but still a large reservoir of still not diagnosed that continues to fuel the epidemic, and having slightly more unsafe sex is enough to offset all antiviral treatment as prevention. So we need to be very, very careful when we communicate about antiviral treatment as prevention, because if people get the perception and that's it, you don't need to worry about any other preventive tool, we're really misguiding the population. And I have the fear that some of this is actually miscommunication and overbelief in one of the intervention tools, namely antiviral treatment. And we spend so much time at the moment discussing CD4 threshold for starting therapy, but it's really not what this is about. If we want to achieve the public health benefit, we want to focus on coverage. If all infected are on treatment, very few transmissions. The more realistic goal is that we need to have the rate of reproduction, which is well known in any outbreak epidemiology. We need to have that number less than 1. So one person infect less than one other person. If that's the case, then any epidemic will die out. We still don't know exactly what are the required coverage to achieve this, to get the R0 level less than 1. But again, if most transmissions occur prior to diagnosis, elevating CD4 cell count for when to start ART is not going to be effective. Testing strategies will be critical. And of course, if source of infection is often very recently infected persons, not even the best testing strategy will work. So this is not going to be easy, but clearly we need to fix this problem before we can really intelligently start to talk about antiviral treatment as prevention in the real sense of the word. So in summary, ongoing HIV transmission remains a major public health challenge across Europe. The main reasons are risk behavior modifications, which is unchecked, major sources of transmission, persons who is not yet diagnosed, and the challenge is, of course, to reduce the percentage who is not yet diagnosed. There's large number of HIV tests performed. I was just in Belarus, where 10%, what amounts to 10% of the population is tested each year. But still, the HIV incidence goes up. And it clearly reflected that the drug user community was not tested. On the other hand, they tested pregnant women twice. So there was 200,000 tests out of the 1 million tests done in pregnant women twice. And so it just speaks out how the fact that countries are investing on prevention, if the investment actually don't make sense, if you don't actually focus on the key affected populations, it really is a very ineffective prevention intervention that you are approaching, that you are rolling out in your population. Normalization of approach to testing absolutely is critical, and it's a challenge at the moment. Sometimes I feel that this becomes a specialty that only a few can do. I think that's wrong. I think a lot of different people within the health systems and elsewhere needs to be qualified in order to do an HIV test, and don't need to really have a skill set that is so extensive that nobody else feels that they're competent to do it. I'm a medical doctor. We do a lot of different tests. Why can't my colleagues do that as well for HIV? There's something about the exclusivity of HIV tests that makes even health professionals afraid of doing it. It's not good enough. We need to work on it. It's a challenge. We need to ensure safe and effective transfer of HIV-positive people to care in all types of testing facilities. Again, we have not really fixed that problem, and we haven't done enough research on how to deal with this and ensure this. And then, of course, finally, to ensure that care is provided in attracting and state-of-the-art facilities. There was just a talk on that, and I don't want to delay on that point. Thank you very much for your attention, and if we have discussion, let's debate.